Welcome. I'm Dr. Ogan Gurel with the talk show Internet TV Insights in Medicine, brought to you by InTimeTV. We have here a very special guest, Dr. Vedat Obuz, who will be talking about unmet needs in primary care medicine. I think it's a very good follow-up to last week's session that we had with Dr. Anderson Hedberg, with the former president of the American College of Physicians. And Dr. Obuz is a very special guest because he spans a number of areas. He is a practicing primary care physician in internal medicine and pediatrics. Did a internal medicine combined med-peds residency. He's also a medical device innovator, and hopefully we'll have a chance to talk about some of those innovations that he's designed to bring to the unmet needs in primary care as described. And he's also a health technology consultant. Dr. Obuz is medical director of the Lotus Medical Clinic and System in New Jersey. He's president and CEO also of MDM Healthcare Education and Research, which develops solutions that meet the unmet needs of the primary care physician of the 21st century. He came to the United States in 1989 as a postdoc and studied leukemia, so he has a well-published scientific background. And as I mentioned, completed Med-Peds residency at Albert Einstein College of Medicine in New York City. He visits us in Chicago, actually, from New Jersey. It's a pleasure to have you, Dr. Obuz.
Thank you.
And looking forward to discussing our topic for today, unmet needs in primary care.
It's my pleasure to be here in Chicago first time in my life, and I'm very much impressed by welcoming of the city and your show here. And to add to your introduction, just correction, the residency program was in Philadelphia, Albert Einstein. So
Albert Einstein, Philadelphia.
In Philadelphia.
Yes,
right. But I'm glad to be here following the footsteps of former president of American College of Physicians, Dr. Hedberg, because a lot of things he has mentioned in your program last week has a lot to do what happens in my life, in my practice day to day, and a lot of things that is happening in the lives of many practicing primary care physicians and who are facing the same difficulties as well as challenges. And I'm here to actually represent and then bring my viewpoint and then some of the solutions I am working on, and with the help of other physicians and the probably hopefully some venture capital we can raise, we will help for the better care of primary care in the United States. As you recall in your last week's program, that Dr. Hedberg has said that primary care is in crisis. Indeed, it's in crisis, and
Yes.
and I've been practicing since 1996 as a Med-Peds practitioner in state of New Jersey, and I have had not seen actually so far that any rectification in the current existing problems.
Right.
And as you know, is that diversity problem is 46 million uninsured is getting increased every day, is a big challenge. We have to find a solution to deliver a better health care and reduce the cost of these people when they become very ill at the shoulders of states and their Medicaid programs. Also, quality of care has to be improved because we have great medicine, the best medicine in the world in this country. We have the knowledge, and as Dr. Hedberg has stated, that we cannot even apply the 50% of the knowledge we have because we are overwhelmed. Also, cost is a big issue, and we have to find ways of reducing the cost while improving the healthcare delivery system. And my companies, including my day-to-day practice, has been working on several aspects of these challenges, and I can simply start with healthcare technology implementation and innovations. And innovations, again, and has to be brought into day-to-day practice of primary care physicians, because it's been shown over and over that it's better coordination of care, also implementation of new outcomes in measures, as well as reducing errors by applying electronic healthcare recording system, will reduce the cost tremendously.
So some of the technologies and innovations you're discussing are not just clinical devices, or as well, there's also the information technologies as well.
Yes, as well. And some of the clinical devices, I believe physicians are great innovators. And as you have seen as a practicing or a physician who's trained in United States, a lot of things have been discovered by physicians that's been in application today. And some of the new discoveries will help also decreasing the cost and increasing better care. And I'm one of those physicians, and I'm proud to bring my innovation side, because I enjoy innovating things that will end up helping people, that will end up helping better healthcare delivery, and also increasing in terms of compliance with the patients and education with the patients, and so on and so forth.
So you see physicians as not just delivering care, but by virtue of their education and engagement with the problems, yes, that Dr. Hedberg pointed out, really in a position to provide solutions, suggest solutions.
Exactly, and especially the companies in big corporations have to realize this and utilize physicians better, because in technology part and in also innovation part, I'm not putting any engineers down, but engineers don't know the unmet needs of the patients.
Well, right.
As well. And we know what they need, and we can develop and implement and correct the devices and technologies according to patients' day-to-day interaction. Human beings is the best creation of God that has been put in 2 feet, but we have a brain and then 5 additional senses, and then we have been acquiring a lot of knowledge in the day-to-day interaction with the patients, and then we have to find ways to put these interactions back into use again.
Well, we'll return to some of those points. We have a break here. I'm Dr. Ogan Gurel with my guest, Dr. Vedat Obuz. We're talking about unmet medical needs on the show Insights in Medicine, brought to you by InTimeTV. Stay right there. We'll be right back.
Yes, you are. Come here. Let's see how this looks.
Hey, how's my little horse?
She's a lion.
Yes, she is.
You don't have to be perfect to be a perfect parent. When you adopt a child from foster care, just being there makes all the difference.
Come on! This way! Who is that guy? I don't know! Hurry up and we're behind us! I know! Come on, get up!
407 years ago.
Think history is a little scary? Then log on to LOC.gov and see how much fun it can be. The Library of Congress at LOC.gov.
Pants. I am folding the pants. The pants are long.
Do they go on my head? Do they? Do the pants go on my head? No. They go on.
Everyday moments can become teaching moments, because learning starts long before school does. Give your child the start they need at bornlearning.org.
I wish I could go back. Back when I didn't need someone to do my hair. Back when I could still say my husband's name. Back when I could have called 911 but didn't. Back when I first felt the warning signs of a stroke but did nothing. I wish I could go back, but I can't.
With a stroke, time lost is brain lost. At the first warning signs, take action immediately.
Welcome back. I'm Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. Our distinguished guest, Dr. Vedat Obuz, Medical Director of the Lotus Medical Clinic. talking about unmet needs in primary care. Just before the break, we were talking about some of the information technologies and how I've studied these technologies to some extent and obviously work with them. There's really a challenge in having physician adoption of these technologies. What is behind that?
There are several challenges.
Yeah.
As Dr. Hedberg stated last week, cost is one of the main elemental challenge that we have, because as primary care physicians, we have been working on marginal budget that is going down every year, and then we do not have extra money to put out to buy these expensive technologies. But not only that, there is lack of transition technologies in current market, as well as lack of good infrastructure for the education and support of these practices. Now, the challenges have been evaded in England and other countries by implementing a national system that was costly initially, but in long run they have shown over and over using these technologies have reduced the cost, and in long run they have saved more monies.
Yes.
And I'm glad to bring it out here that recently Medicare has sent memo to hospital executives that they opened a window in the kickback laws that hospital executives now can help primary care physicians in their neighborhood to adopt these technologies up to $15,000 per physician. That is a good start, but it is not enough, because the existing technologies have not been prepared to adjust the current thinking of old school doctors like myself. I call myself old school doctor because I've been in practice over 12 years, but
well, let's call it traditional.
Traditional doctors.
Yeah.
In traditional doctors, what we see, what we think, and what we put on the paper. We want to adopt a system that always incorporates this. And then I have not seen visual-based EHR program yet. And
EHR, electronic
health record, which is EMR, its new name. And we are working on a technology as we speak with my programmers to bring all these challenges into a lowest level, so acceptance by the physicians and usage by the ancillary staff will be very easy.
Right.
And also one other aspect of the electronic medical record adaptation is there's a transition program need to reduce or store the existing paper records. We have developed some and there are existing other products in the market to incorporate these less than $1,500, $2,000 budget per physician, so you can have all your existing records you can go refer easily in digital format. These has to be done, but this has to be made available to a variety of practices throughout the United States, and lack of support in our hand in making this available to others is challenge for my company and myself, but other physicians also have to have easy access to these products and in time to train their staff. That is a great area of medicine that needs to be looked into and promoted. And I believe in state levels, every state governor should create a project and a budget to help and ease in transition. And also,
is that going to be related to the Medicare, Medicaid memo, or is that a separate program?
Separate programs need to be done. The reason is I believe the governors of each state can reduce cost by utilizing centralized medical record system, especially streamlining for medication usage and alternative providing. We have been working on some of the similar products that to show that the existing HMOs that is going to save a lot of money for them. Why not expand this to the state levels as well?
So that's a drug formulary system.
Yes, drug formulary system, because that also is going to reduce some unnecessary time lost by the physician and the pharmacist, and also bringing available low-cost alternative to the pharmacist, streamlining the process. We call this mychoiceprescriptions.com, and then it's going to be available soon from East Coast states to rest of the United States. We are working on this program very easily.
So that website is mychoicerx.com?
mychoicerx.com, yes. And we will have open enrollment soon for the program.
So what that does is every physician has a certain formulary, if you will.
Yes.
And if that doesn't necessarily fit with the patient's insurance or the pharmacy system, then the pharmacy can access mychoicerx.com and see what that physician would prefer as alternatives.
Exactly. And this is not only based on physician, it's called be tailored per insurance also.
Right. You have tailored for the physician and tailored for the insurance.
And I believe it's a great headache reducer for day-to-day primary care physician. I have done a small study in my county, and then every physician is receiving more than 15 phone calls a day. And in reducing these phone calls, I have calculated we are saving at least 1 hour time per pharmacist for each pharmacy. And it's a great way of helping improving the outcome of healthcare, reducing the cost as well.
Right. So as Dr. Hedberg mentioned last week, uncompensated administrative overhead is a real problem for primary care physicians.
It is. It's a big headache, and then 50% of actually what we do day to day is not compensated.
That's what he quoted.
Yeah, and there is no way for us getting paid for these services. Prior authorizations is a headache, and we have no way of documenting this and getting paid. And also important preventive measures are not reimbursed by a lot of, including Medicare. So these are the things that urgent needs of primary care physicians has to be solved right away. So
electronic health records
and unpaid
administrative
costs, and also streamlining a process of delivering better health care in preventive care, actually improve preventive care in primary care.
Right.
Which comes to the next subject we should be talking is
well, we'll talk on that topic. We're getting ready for a break.
Yes.
This is Dr. Ogan Gurel with Insights in Medicine, the InTimeTV program, with our guest, Dr. Vedat Obuz. Stay right there. We'll be right back.
Once they've outgrown their toddler seat, they're still not ready for adult safety belts alone. 4'9" is the magic number. Until then, kids need a booster seat. Make sure your little pumpkin gets there safely. Visit boosterseat.gov.
Protect yourself from mannequinism. Volunteer. Vote. Stay informed. It's easy to get involved.
Can I ask a few questions about the apartment on Park Street?
What was your name?
My name is Juan Hernandez.
It's been rented.
Hello, my name is Sanjay Kumar. I am calling about the apartment on Park Street.
It just rented.
My name is Tyrone Washington. I'm calling about the apartment for rent on Park Street.
It's not available.
I use a wheelchair and...
It's gone.
Hello, my name is Graham Wellington. I'm calling about the apartment for rent on Park Street. Is that still available?
Yes, it is.
Oh, it is?
Housing discrimination is illegal. If you think you've been a victim, call us.
Before you start an online relationship with a guy, think about how it could end.
Welcome back. You are watching Insights in Medicine, the Internet TV talk show brought to you by InTimeTV. Our guest, Dr. Vedat Obuz. Before the break, we were just about to embark on another topic, following up on our discussion on information technologies in healthcare and some of the unmet needs in primary care related to that. The next area of innovation and unmet needs are some of the clinical technologies.
Yes.
Tell us a little bit about your insights and work in that area.
As we have been discussing prior to break, preventive management is the key to success in primary care, and then we need to have right tools in our hand to help our patients, and then the tools that not only doctors will easily incorporate into their practice, but patients will use also.
Mm-hmm.
As you know, asthma, diabetes, along with hypertension, one of the main healthcare dollar consumers. And in consumption of healthcare dollar, asthma comes on the top of the lists. And as you know, every doctor knows and every patient knows is the key to success in treating asthma is prevention by using inhaled corticosteroids.
Prevention of hospital visits. Not so much prevention of the actual asthma.
Yeah, actual inflammation actually in the lungs.
Yes, right.
And this will reduce it. But compliance becomes a big issue. And patients need to have devices to increase the compliance. Also, doctor needs to have a device that helps the patient to educate the patient as well. So I've been thinking in this line since I entered to my first day of practice in the training program, and I came up with a device. Actually, the device itself, it fits in my pocket, as you see here. This device is a 4-in-1 device. It helps patient in asthma care in several ways. We have patented this device and named RespoWell, and several aspects of this device I will show you. When you open the device, it is small enough to fit into your pocket.
Open like this?
Yes, and it's made out of a durable plastic. And when patient uses this device, you have a retraction when you come out. You have a
pull
canister,
that out.
pull that out, and you have a canister carrying portion of this device. When you open to use the device, you have a section here, as you can see easily. It's going to be used to transmit your messages as a doctor to your patient. Peel out your note and stick it here.
Hold your breath, that sort of thing.
Yes, instruction as well as actually memos.
So not just related to the device, but related to the broader care of asthma.
I will be writing here, if you are using rescue medication more than twice a day, you're doing something wrong, come and see me.
Yes.
That's my message is going to be. Now, second aspect of this device is that we are patented a device that holds the two canister, not in one, in this position, and two canister, one being inhaled corticosteroid, the other one being is bronchodilator, short or long acting, will be a way of reducing cost of the medicine also, because existing medications that combine in the pills or in the inhaled products cost more than if you use them separately. Also, we have another aspect in device. I take it out and show you. In the area where the medication dispense in regular MDIs, you have a straight shooter.
MDI, metered dose
inhaler, straight shooters. What we have incorporated to make it easily seen in TV, I'm bringing our first prototype made out of metal. We have a swirler action, actually swirling action producer, a tip which is going to be incorporated here. And from this tip, when the air comes out, it comes out in 4 directions. So it gives a spinning action to electrons. And these electrons will be going into the chamber, which is coded statically, so it doesn't stick into it. And with the spinning action, the electrons, we have more of the molecules go all the way to alveoli in the lower part of your lungs. Better delivery, less medication use, and better outcome. So
that's almost like in a rifle.
Yes.
Where there's rifling of the barrel.
Yes.
That has increased the range of bullets and all that. And what's really nice about this is rifling technology happened just before the American Civil War.
Yes.
Made that a very lethal war. 2 million Americans died.
Yes.
now that sort of idea is being applied for life-saving
Yes,
medicine.
hopefully we will save more than 2 million
Those
lives.
molecules save more than 2 million lives.
Yes, that's the aim. So this is a simple example of applying innovation in healthcare to bring better outcome in preventive medicine, in education, and cost reduction.
Right.
So I'm hoping that my other colleagues will bring into more of the ideas in their head into live action like this device, and then we will utilize them, all of us.
What do you think? It's very interesting that you note this. I mean, obviously, medical innovation doesn't just come from physicians,
Yes.
but I think one of the themes of today's discussion is physicians have to be at the center of some of that,
Yes.
and in fact can be a great source of ideas. What is preventing more physicians from getting into their ideas getting out into the market?
Number one is lack of time.
Yes, of course.
Because we have to work harder. In old good days, as you recall, physicians used to work 4 days. Play golf Wednesdays.
Right.
I don't even know how to play golf because I don't have time because I work 6-7 days.
Yes.
Most of the time. We take less vacations, work harder. Number one. Number two is we don't have the tools of the corporation structure raising money, utilizing venture capital. Because as doctors, we have not been taught this business aspect of medicine,
Yes.
and we don't know what to do next. Number three is also adaptation of our ideas by our own colleagues, because physicians especially are very resistant to adapt to new technologies and ideas.
So it's almost like an ego issue?
Ego issue, yes, exactly.
Not invented here syndrome?
Yes.
Even
yes.
though here's my golf buddy,
Yes.
I don't want to do his technology.
Exactly.
Or his or her.
These
Okay.
are the challenges I have experienced myself, and it's a known factors by double-blinded studies, if I may call. So if you overcome all these things, I think we can bring out very good things into the market and in patient care. And then we have to just work hard to overcome these challenges.
Now we're going to have a break. Certainly, this interview with Dr. Vedat Obuz, time flies very fast. Very fascinating interview. We still have obviously quite a ways to go. We're going to talk about some more fascinating topics right after the break. This is Dr. Ogan Gurel with Insights in Medicine. Stay right there.
Two words for you. Pop quiz. Ready? Name any funny movie. A drama. Name a mystery. And one more thing. Name the movie your kids saw today in science class.
Know what really matters. Know about your kid's school. And know about your kid. Find out 100 ways to know more, do more.
There's something about you, baby. I can't get enough. There's something about you, baby. I got you looking at me, I'm gonna call you bluff. There's something about you.
The smallest moments can have the biggest impact on a child's life. It takes a man to be a dad.
To the morning light. Listen to smoke before you give it a try.
Only you.
Don't play with matches. Don't play with fire. Cause there's nothing very funny about ring-down fight. Nothing very nice. Holy smile. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Mom?
Dad?
How long should I wait for you?
If I'm at soccer practice.
What if something happens? Will you come get me?
There's no reason not to have a plan in case of an emergency.
Should we go to the neighbor's house?
And some extremely good reasons why you should.
Can you tell me?
Talk to your family about what you would do in case of an emergency.
Welcome back. I'm Dr. Ogan with the InTimeTV show Insights in Medicine. Our guest, Dr. Vedat Obuz. Before the break, we've been talking about a number of unmet needs in primary care and some solutions to those, including improvements and challenges and opportunities in electronic health records and related aspects thereof, and also clinical technologies with this new asthma spacer technology. I wanted to also speak more broadly about elements of primary care which were highlighted in Dr. Hedberg's talk in our talk show last week. And Dr. Hedberg clearly had outlined a number of challenges to primary care. Primary care in crisis has been one of the themes of his work and the American College of Physicians and bringing that awareness. But he also proposed some very comprehensive solutions. And one of those solutions was the medical home concept. And please tell us a little bit, since you're in the trenches, as it were,
yes,
a practicing primary care physician, tell us about the medical home concept, what you understand about it, and how you're interpreting it.
Medical home concept is as Dr. Hedberg said, it's not serving patient in their home, but becoming home the center core of the more of the care and the coordination of that care. That requires, in the center of this concept, as a physician, if I may make a resemblance, as like an orchestra chief, and coordinating the care, utilizing his ancillary staff, nurses, and other healthcare providers, and then communicating in a smooth way, and bringing the patients into the home, which is the practice site, whenever they need it, before they require hospitalization. Now, in this concept, American College of Physicians is hoping to reduce the hospitalization and cost, and improving the communications and the healthcare delivery. Now, in increasing healthcare delivery and applying electronic medical record is also core portion of this concept, requires also implementation and using of the developed disease management concept and an application into patient care. There are a lot of studies ongoing, as he mentioned, and to show the data saying that it really works. We know that it works and it is going to work, but there are more challenges on it, and then there are ways to overcome it. Also, in my viewpoint, there are portions are missing, and then I am actually, as we speak, applying these portions into my day-to-day practice.
So the medical home concept is about coordination of care, and in particular, primary care physician is the conductor of that. But there are some additional aspects that you feel are unmet and you're meeting.
Okay. One of the aspects that I have noticed that the current concept is not addressing the 46 million uninsured, and then providing a medical home for them and in a reduced cost way. I have been blessed in one way, having a portion of my practice in South Jersey that has several uninsureds that's looking after care in my practice, and then I have developed in certain ways to helping them and reduce the cost and providing the care in a better way than other practitioners are doing. One of the area that I help my patients is that providing medications, generic medications, through video pharmacy concept in an arrangement, and availability of pharmacists to counsel them, but dispensing the medicine without additional cost of utilizing retail pharmacies. That is one concept. It could be incorporated into medical home care, so we will reduce the costs for these uninsured patients.
So the way that works is you're dispensing the generic medications in the office.
Yes.
And you're providing videos that provide the pharmacy advice?
Actually, live pharmacies are available through video conferencing.
Through the video.
Video conferencing.
Right.
Now, one of the things. The other things is that we do provide in patients who need care at their home. We go to their homes, especially patients in elderlies in difficulty getting into transportation, coming to our offices. One of my offices have not been set up in a wheelchair accessibility. Patients on wheelchair, I go to their homes.
Yes.
So that's one of the aspects I have not seen in ACP guidelines or ACP's model. Also, alternative medicines have not been applied. We don't have to be afraid of alternative medicines. As I have been using alternative medicine concepts and also herbal medicine in my practice, I see benefits of it. For example, in China, a tea called gotu kola has been widely used. And this tea...
How do you spell that?
G-O-T-U. Next word is K-O-L-A. Gotu kola.
G-O-T-U.
G-O-T-U, yes. Gotu kola. Yeah. This tea increases microcirculation. Also helps in terms of mild depressions and also even schizophrenics, they use it in China. I have seen great improvements in my Alzheimer's patients who have been maxed out on 2 existing medications in the market. Very expensive medications.
Yes.
Now, another alternative herbs that I use all the time is called...
How come we don't hear about this herbal tea from China?
I've been actually blessed to have a friend who is an acupuncturist in Philadelphia, who I became very close in certain projects we were together, and he's been teaching me. I send him patients day to day, and then he has great herbs that he provides, and current medicine doesn't help these patients. There was a patient actually in my practice who has allergic to prednisone. Can you imagine? This woman had the worst case of eczema.
That's like impossible.
Impossible to treat.
Yeah.
He has worked on this woman over 6 months. She's totally cleared. There's no allergic reaction eczema in her body last 5 years.
So in a way, I mean...
There is a niche, but
yes.
Only overutilize, but when needed, know how to use and utilize alternative medicine. Even
so you would almost, that's more complementary medicine.
Complementary medicine. And whole care medicine also.
Yeah.
Whole care, when we say whole care medicine, we see human beings as a whole. Not only the physical human that you see, with the feelings, with the beliefs, with soul and other energies inside of this package.
Yes.
Where it comes application of faith-based medicine and spirituality and mind-body connection implementation into practice. When the right time comes, I utilize these things also.
Well, we're shifting to a break now. Basically, we were just talking about the medical home concept and some interpretations and additional applications of that. This is Insights in Medicine. We'll be right back.
My pot of gold, your daddy's little girl, till heaven home.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
You know, I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
Thank you. That's really not necessary.
No. Come here.
Welcome back. I'm Dr. Ogan Gurel with the Insights in Medicine talk show on Internet TV, brought to you by InTimeTV. Our guest, Dr. Vedat Obuz. In this segment of the discussion, we've been talking about the medical home concept, advanced by the American College of Physicians as well as other organizations, and some of the additional thoughts and interpretations and applications of that concept to private practice in the trenches, as you are. During the break, we were talking about your doctor's bag, and you were saying one of the aspects of that is actual home visits. Again, the concept of medical home is not so much in the home, but in fact, visiting patients in the home, house calls, is a part of your practice.
Yes. House calls are essential in certain areas.
Right.
And it should be used in balance. And then if it is done properly in a way that it can save hundreds of thousands of dollars in single practice, per practice actually for the medical
Can you give some examples of,
for example,
what are your criteria for a house call?
My criteria are a little strict, but other physicians may expand this if they have resources. Like
Yes.
if you happen to have a nurse practitioner in your practice, literally you should and you can do house calls once a month to every Medicare patients. As you know, in the elderly age above 65, medical problems increases. One of the medical problems we encounter the most is major depression, untreated major depression.
And you may not really see that in
they
the
are
office.
homebound.
Yeah, right.
We have figured out by doing calls, and then some of them don't even have a phone in their homes because they cannot afford in the urban setting. We have done visit to these houses and found out that these patients have not been in touch with the real world more than 3 to 4 days and 5 days. Then we got proper help, proper medication, and save them going into coma. And as you can recall from your medicine trainings, one of the challenges or interesting patients you get it is hypothyroid patients. They end up coming to emergency room with coma as John Doe or Mary Doe. The reason is simple blood test has not been done to show the hypothyroidism on it. So when we go to home with this bag, we have in this bag is portable pulmonary function test, EKG, PC-based EKG. All supplies you need to get the blood tests, sugar test, you name it. So with simple stick into the finger, we are able to get patients on time, on spot, sugar, and then necessary blood work, bring it to office and sending it. And we are catching the patient before patient ends up in emergency room and treating them.
So that's interesting. Your house call concept is less an emergency house call than a scheduled house call for certain selected patients.
Exactly.
Either disability, Medicare, elderly, and so forth.
Yes. House calls are made for patients actually who don't have health care coverage also. I have encountered one patient who happened to immigrated here, but it was in the window period, wasn't eligible neither for Medicaid nor Medicare, and had a great family. God bless her soul. We lost her 2 weeks ago for after being home for 2.5 years. She had a slow-growing cervical carcinoma, and I have cared for this patient over 9.5 months by visiting him and getting proper medication and then transfusion before she get out of the hand, transportation, arranging the transportation just for a transfusion. Otherwise, this woman would have been in the hospitals for 3-4 months because there was not enough arrangement. So we were able to do this. I have data showing and documentation showing. So house calls are an important part of primary care, should be incorporated in the concept of medical home care. But I have other concepts that I have been working on in my practice, which I'd like to share with every other physician. Now, preventive care in primary care and also application of disease management has to be done before it's broken. Now,
before the patient presents.
Yes. And a lot of data and research has been done after the fact. I call my implementation and implementation on this area is beforehand implementation. As I have shown you in remote access to my server, we have developed a simple touchscreen-based surveys. These surveys are presented to patients in the triage room, 30-second surveys by the nurse or patient itself. And it's focused on patient's disease entities. If patient has told my nurse or to the computer said that she has not or he has not had hemoglobin A1C done 3.5-4 months and did not have the pneumonia in a diabetic patient, I will get a printout in my hand in the room when I'm seeing this patient. These are the missing parts, and I will order them, and I will fix the problem on the spot. I will not make this part of the data that is going to require fix up 6 months or 1 year down the line. So this is the preventive care concept has to be implemented into day-to-day practice of medical home care. Other aspects, as we spoke with the electronic healthcare record, also coordination of care, communication. Now, lack of communication between physician, HMO, or state, or pharmacist can create a lot of difficulties. Frustrated patients, frustrated doctors, overwhelming phone calls, and frustrated pharmacists. I have solved all these problems with mychoiceprescriptions.com concept, and I'm hoping to get this into action very soon.
With respect to multiple drug
formulary issues. That's a big issue, and it's not going to go away. But it will help healthcare providers to streamline their process and also reduce costs for the HMOs and insurance companies. So we have several things to adopt. Everything is doable. We just need to work together and then make it easy in terms.
Well, I want to shift gears a little bit more internationally, to the extent that I know from your CV and your background that you've done a lot of work and are planning a lot of work in the international setting. And I think that's very fascinating because we've talked a lot about the American healthcare system. We're on the internet, and the internet is global. So we're going to take a short break and talk about international medical aspects and medical diplomacy. You are watching Insights in Medicine, brought to you by InTimeTV. Stay right there.
Family and friends can provide the support you need to reduce your risk of cancer, diabetes, heart disease, and stroke. Eat right and get active.
Impossible.
It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Welcome back. I'm Dr. Ogan with Insights in Medicine, brought to you by InTimeTV, internet TV talk show geared towards primary care physicians, general practitioners. Dr. Vedat Obuz, a very interesting combination of practicing physician in the trenches with individual patients, and you gave a very touching story about a cervical cancer patient, and obviously very sad story in the end, but I think she sounded like she received some help, a lot of help, yes, over the course of her illness. So working with individual patients, but also developing innovative technologies, thinking outside the box, outside the spacer, the metered dose inhaler. Can I take a look?
Yes.
This is the box, outside the box.
Yes.
But also globally, and I know you've done some work globally, and indeed, we're all human beings, whether we're here in the Western Hemisphere, in the United States, or in Asia, or Europe, or Africa, or wherever.
Yes.
I mean, medicine is medicine. Tell us a little bit about medical diplomacy and some of your international medical work.
As I have mentioned earlier, medicine in America, the U.S. medicine is far advanced than any other country in terms of knowledge base, technology, and quality. What makes America's healthcare quality far above than others, though a little more expensive, is the great infrastructure, ancillary healthcare providers we have, and their great trainings. And I believe lack of these parts in the rest of the world makes a lot of physicians to come to the United States to practice, because you have a great support on your right hand. You have great trained nurses, you have great trained technicians on your side, and then your success depends on them. Now, being originally from Turkey and owing that country a lot, who brought me up all the way to medical school, and committed to, and then closely connected with my family still there, I have been doing projects in Turkey. And some of the projects are improving in education portion of ancillary providers.
So in a sense, bringing United States teachings, advantages, understandings that make our health system great, notwithstanding the problems that we do have, to other countries.
Exactly. And I have been working closely with a New Jersey-based school who has license options, international license. Now, not only people we train there are going to continue help in medicine in their country, but in the future to improve their skills, part-time and short-time, they are going to be able to come to the States also, because their diplomas are equivalent in United States. Now, we are also working with nations in West Africa closely. I have had several patients in Trenton, New Jersey area that has escaped from Liberia and West Africa in the past. Now they are all getting ready to go back to their home countries. They are returning, and then
they have a new president there.
President, and then she's an excellent president, and then trying to do her best for that country. And I'm closely working with the president of Liberia and the Ministry of Health to bring some of the know-how, knowledge, and also help from our end to Liberia to start from scratch, better healthcare delivery system there.
So medical diplomacy, I mean, in terms of, obviously this is a win-win situation for both countries or both peoples, but it's not so much about U.S. doctors going over, treating patients, coming back. That's very important.
Yes.
And we hear about that often, for example, tragic situations where patients in war zones lose legs and limbs from mines, and then plastic surgeons go and help fix them and so forth. But this is more about knowledge transfer.
Knowledge transfer is important for several aspects. Number one is that you cannot be there to fix that leg all the time, but if you teach what you know to one person, that person can fix 100 legs. A great friend of mine is doing is sabbatical from his practice in Kenya right now, teaching residents orthopedics in the knowledge that he has. And when I asked him, I said, he's originally from Turkey also, Eric Goshen. I said, Eric, why are you going there and then leaving everything behind? He said, I have realized that I can go and work in a hospital and then do 20 operations in a month. But if I spend 8 months training 20 physicians, and each one of them, the rest of their life, they can do hundreds of thousands of surgeries and help that many people. So that is the concept that we must work on, and we should work on in helping other nations. And this concept also increase dollars and cents in what comes back to us also, because some of the technologies are going to be utilizing what we manufacture and do here in the United States.
Yes.
So it is not just in giving away, but teaching somebody to be on their own feet, giving them the proper knowledge, and providing them what needs to be utilized by them. So this is what we are trying to do. And I'm hoping that we will expand this notion and knowledge to Asia and rest of the world, wherever we get us to do so.
So you're working with the Ministry of Health in Liberia?
Yes.
And
a private company in Turkey. We are working on actually tertiary care hospital concept, and also providing manufacturing facilities for handicapped. In Turkey, there is not enough manufacturing facilities to provide whatever is needed for the handicapped patients and people, and also rehabilitative services. We have a great concept. We are working on it.
And actually, that's where I've traveled a lot in Europe, and Europe, obviously, advanced Western countries, but to some extent, the United States is very advanced with the American Disabilities Act, etc., in providing for handicapped individuals.
Yes, and then one of the concepts we don't even have here, we are working over there in Turkey, is providing medically ill, handicapped, accessible holiday resort centers for patients and their families. And soon we will have this project going on, and we can even take handicapped patients from United States there to spend their vacation. There will be like ways of getting wheelchairs all the way to the sea for them to enjoy the water.
Great. So we're talking about medical diplomacy and the international context of applying U.S. knowledge about healthcare and so forth. I think it's very important. You're watching Insights in Medicine. We'll be right back.
This is fine. Thanks.
Welcome back. I'm Dr. Ogan Gurel. Our hour is almost over. It went very quickly. A lot of fascinating topics. Dr. Vedat Obuz, Medical Director of the Lotus Clinic, practicing primary care physician, inventor and innovator, and also medical diplomat. Thank you very much for being with us, sharing your perspectives and stories.
I'm glad to be here, and I'd like to thank you and InTimeTV for giving me this opportunity to be here and share my ideas and thoughts. And I'm hoping that this small segment we have here will spark better, more insight medicine topics and guests here.
Well, thank you very much. One of the things while we were talking that came to my mind was early in my medical training, I remember a professor, very traditional, saying you'll be taking care of patients one by one, but never forget that you have to think much more broadly about all patients. Yes. And that when you learn something and have some innovation or some insight, to figure out how to bring it to the wider world, and not every physician has that opportunity, looks like you do, and certainly that's a really wonderful thing, and I think it's also important for every physician to consider not only their individual practice, but the way they can benefit the wider patients. So this is, thank you very much again, Dr. Vedat Obuz. This is Dr. Ogan Gurel with Insights in Medicine. Next week we have Dr. Annabelle Voldman, Medical Director of the Rush Women's Heart Center. It's going to be a very interesting discussion next Saturday. See you then.